Hi, and welcome back to the Pro-PA Podcast. I'm Angie Urbina, your host for this cardiovascular series. In today's episode, we're diving into something every clinician should know: how to recognize and differentiate the types of shock. Whether you're working urgent care, family medicine, or a fast-paced ER, identifying shock quickly and knowing what to do next can save lives. We'll go through the foundational approach and break down the four major types: hypovolemic, cardiogenic, obstructive, and distributive shock. Let's get into it. Now, let's start at the beginning. What is shock? Shock is a state of cellular and tissue hypoxia due to reduced oxygen delivery, increased oxygen consumption, or inadequate oxygen utilization. This can be due to a drop in circulating volume, a failure of the heart pump, a blockage in blood flow, or massive vasodilation. No matter the cause, the key issue is cellular and tissue hypoxia, and our job is to figure out what kind of shock it is and fix it. So how do we know someone is in shock? Features that are highly suspicious are the following: hypotension with a systolic blood pressure of less than 90 millimeters of mercury or a mean arterial pressure of less than 65 millimeters of mercury, tachycardia, signs of end organ hypoperfusion, think cool, clammy skin, altered mental status, and decreased urine output, metabolic acidosis, tachypnea, and lactate can also help because it tends to rise as tissues become hypoxic. The first step in managing shock is to assess airway, breathing, and circulation, and establish IV access to begin fluid resuscitation with IV crystalloids promptly. Do not delay resuscitation for diagnostic tests or central line placement. In undifferentiated hypotension or shock, rapidly determine shock severity and whether immediate, life-saving interventions are needed. These interventions may include intramuscular epinephrine for anaphylaxis, pericardiocentesis for cardiac tamponade, chest tube for tension pneumothorax, surgery for hemorrhage or aortic dissection, cardioversion or pacing for arrhythmias, IV antibiotics for sepsis, revascularization for myocardial infarction, thrombolytics for a massive pulmonary embolism, and IV steroids for adrenal crisis. Once the patient is stabilized, conduct a thorough history and physical exam. Assess mental status, mucous membranes, jugular venous distension, lungs, heart, abdomen, skin, and joints. Bedside telemetry and/or electrocardiogram is also necessary. And you'll want to order the following labs: a CBC with differential, complete metabolic panel, lactate, cardiac enzymes, B-natriuretic peptide, coagulation studies, D-dimer, and arterial blood gas. And a point-of-care ultrasound and portable chest X-ray should also be done in most patients. If the diagnosis or type of shock is unclear, pulmonary artery catheterization may help, especially in patients with severe cardiogenic shock, unclear volume status, or suspected pulmonary hypertension. Fluid resuscitation is typically started with 500 to 1,000 milliliter boluses of crystalloids, and if this fails to restore tissue perfusion, start vasopressors. However, in hypovolemic shock, continue with fluids as first-line therapy. The goal is to maintain mean arterial pressure between 65 and 70 millimeters of mercury, as higher targets may be harmful. Now, once the diagnosis is clear, treatment is refined as per the underlying cause, and response to therapy should be monitored through mean arterial pressure, urine output, mental status, and serum lactate levels. Next, we are going to go through each type of shock briefly. First, hypovolemic shock. This is due to volume loss. Think hemorrhage, dehydration, or burns. There's just not enough fluid in the tank. Clues are flat neck veins, reduced skin turgor and dry mucous membranes, cool extremities, low central venous pressure and preload, and often there's a history of vomiting, diarrhea, trauma, or bleeding. Management includes fluids. Crystalloids are first line, and if bleeding, add blood products. Second is cardiogenic shock. This is pump failure, usually due to a myocardial infarction, arrhythmia, or end-stage heart failure. Clues include jugular venous distension, pulmonary edema, cool extremities, and there may be elevated troponins or signs of ischemia or arrhythmia on electrocardiogram. Management includes inotropes like dobutamine, vasopressors, oxygen, and revascularization if there's an MI involved. Next is obstructive shock. This is when something blocks blood flow. Think pulmonary embolism, cardiac tamponade, or tension pneumothorax. Clues are that this is usually rapid in onset, jugular venous distension, pulsus paradoxus in cardiac tamponade, and diminished breath sounds or tracheal deviation in a tension pneumothorax. The management is to treat the cause. For example, needle decompression for tension pneumothorax, pericardiocentesis for cardiac tamponade, and thrombolytics or anticoagulation for pulmonary embolism. Last up is distributive shock. The classic example is septic shock, but don't forget anaphylaxis and neurogenic shock. Clues are bounding pulses, warm extremities at least initially, low systemic vascular resistance, and normal or high cardiac output. For sepsis, the management is IV fluids and early antibiotics, intramuscular epinephrine for anaphylaxis, and for neurogenic shock, this would be vasopressors, supportive care, and fluids with close monitoring of volume status. Here are some clinical pearls. Number 1, shock is a clinical diagnosis first. Don't wait for labs to confirm what you're seeing. Number 2, warm extremities usually mean distributive shock initially. Cold extremities suggest cardiogenic, hypovolemic, or obstructive shock. Number 3, central venous pressure and jugular venous distension can help differentiate. This is low in hypovolemic and high in cardiogenic and obstructive shock. Number 4, when in doubt, ultrasound is your friend. Check the heart, lungs, IVC, abdomen, and proximal lower extremities for deep vein thrombosis. And number 5, start with ABCs and don't delay resuscitation. All right, let's get some practice in. Question 1. A 62-year-old man with a history of hypertension presents with shortness of breath and chest pain. He is hypotensive and tachycardic. On exam, he has elevated jugular venous pressure, bilateral crackles, and cool extremities. Bedside echo reveals poor left ventricular function. Which of the following is the most likely type of shock? Is it A, hypovolemic, B, cardiogenic, C, distributive, or D, obstructive? I'll give you a couple of seconds. If you chose B, cardiogenic, you are correct. This is classic cardiogenic shock, which remember is due to an intracardiac cause. Signs include elevated jugular venous pressure, pulmonary edema, cool extremities, and left ventricular dysfunction. Question 2. A 45-year-old woman presents with confusion, fever, hypotension, and warm flushed skin. You suspect septic shock. Which of the following is the most appropriate initial step in management? Is it A, start norepinephrine, B, administer IV fluids and broad-spectrum antibiotics, C, order a CT scan, or D, give high-dose steroids? If you chose B, administer IV fluids and broad-spectrum antibiotics, you are correct. Early fluid resuscitation and antibiotics are the cornerstones of sepsis treatment. Vasopressors like norepinephrine come next if fluids don't restore blood pressure. Great job! And that wraps up our overview of the types of shock. Recognizing shock early and knowing how to distinguish the type is key to saving lives, especially in primary care, urgent care, and ER settings. Keep an organized approach, know your clues, and treat fast. Until next time, stay sharp and keep showing up for your patients. And as always, this is the Pro-PA Podcast, where future pros in medicine are made. See you next time.